Good evening, everyone. On behalf of Intas Pharmaceutical Limited, I, Dr. Mithilesh Nayak, welcome you all to this ninth edition in the webinar series Practice Pulse in Endocrinology. And today we are going to discuss about one of the vital issue in day-to-day clinical practice, and that is the electrolyte disorder. And to guide us and moderate today's session, we are having with us Dr. Subhankar Chaudhary, sir. He is a professor and head at Department of Endocrinology, SSKM Hospital, Kolkata. He holds the position of editor-in-chief in Indian Journal of Endocrinology and Metabolism. So, I request Dr. Chaudhary, sir, to take us further. Over to you, sir.
Thank you very much. Very good evening to all of you. We started this journey actually the planning started right at the height of the lockdown days. And then actually, I think we had the first session in June of 2020. And I do understand the situation has changed quite a bit on the ground level. And people have less time now to attend to this. We had fantastic response so far. And I do hope we are doing some service to our physician community. Now, electrolyte disorders, of course, could be dealt with any practicing physician. And in fact, if you look at the Harrison's textbook of medicine and the section on care of hospitalized patient, the first section is on electrolyte and acid-base disturbance. Now, endocrinologists are very important internists, I believe, and could contribute significantly to our understanding and also management of electrolyte disorders, which is so very common, which can be relatively non-specific in its manifestation and the management also, but nonetheless do have very significant effect on morbidity as well as mortality, and management nuances are there, of course. So without much ado, let me try and introduce our very eminent panel this evening. And we are so very lucky to have two eminent endocrinologists, one, let's say, from the north and one relatively more from the south. So we have Dr. R. Muralidharan, who is the Director of Endocrinology at Fortis Hospital at Mohali, Chandigarh. He was formerly Associate Professor in the Department of Endocrinology at PGI Chandigarh, and of course he left and went on to greener pastures relatively early. And he is, of course, a regular faculty in all the conferences and has numerous publications. And I would only like to add that Dr. Murli has this flair of whenever he speaks, he puts in his own judicious sort of take on any subject. It's not just does a good summary of the job, but he puts his own mind to it. And we have as a second speaker, Professor Rakesh Sahai, who is Professor and Head Department of Endocrinology at Osmania Medical College and Hospital, Hyderabad. He has been a very important member of the Endocrine Society of India, holding the post of secretary for several years. And now he is the president-elect, so will be becoming the next president of the Endocrine Society of India. So we are very happy to have Professor Rakesh Sahai, and he has got numerous publications to his credit. So the real challenge today is actually, I must admit, before our speakers, to try and manage these vast topics into 20-minute nutshells. But I'm sure with their past experience, they will do so that we are left with time to discuss the questions that invariably crop up in our chat box. So the first topic is for Dr. Muralidharan, and he will take us through hyponatremia. So sort of it's been captioned as suspect, evaluate, and manage. Over to you, sir, Dr. Muralidharan.
Thank you, Dr. Subhankar. It's really a wonderful opportunity to speak on this very important topic. As you outlined, this is a very, very important topic in day-to-day practice. I don't know why it's not moving.
Yes, if you would click on the screen itself.
Yeah, now it's okay. Let me summarize what I'm going to speak in the next 22 minutes. It's the most common in-hospital electrolyte disturbance. A good history clinical examination assessing volume status optimizes the approach to investigation. It should not be a blind treatment of any low sodium value with 3% saline as is done by any junior medical officer when he sees such a patient in the emergency. A plasma and urine osmolality and urine sodium, these simple investigations can be used to guide the further investigations. And rational management requires a clear understanding of normal physiology and pathophysiology, because injudicious correction can cause deleterious consequences by overriding the body's adaptive mechanisms. And vasopressin receptor antagonists are a new tool in our armamentarium, but need judicious use. So I'll be covering some of these in my next slides. How do you suspect? I'll start with the case Vinay. In such a scenario, it's always imperative that we'll think of hyponatremia, and we actually actively look for it because this is a post-operative pituitary tumor. Preoperatively, he was normal, euthyroid, eucortisolic. The sodium was 141. On day 2, there was some obtundation, and the serum sodium which was got was 128 milliequivalents per liter. So by definition, he fits into definition of hyponatremia, which is any plasma sodium less than 135, and it's associated with increased morbidity and mortality, as well as increased duration of hospital stay, irrespective of the cause of admission. If you look at hyponatremia classification, this patient will come under what is called acute hyponatremia because he has developed it within the 48 hours. This is the cutoff point for acute versus chronic. We can classify into moderate versus severe or profound. The cutoff point of 125, less than 125 is considered to be severe or profound. It can be symptomatic versus asymptomatic. This patient had acute as well as symptomatic hyponatremia. Then classification wise, if you want to really find out what is the etiology, there are two modes by which we look at it, whether it is hypotonic, isotonic, or hypertonic, by measuring the serum osmolality and also looking at the volume status of the patient clinically and with some simple hemodynamic parameters, whether he is hypovolemic, euvolemic, or hypervolemic. Each of these has its own pitfalls, but this is the simple classification by which we approach the patient. As I told you, hyponatremia, which is clinically significant, is always synonymous with hypoosmolality because normally sodium is the major contributor to plasma osmolality. There are two exceptions where there can be low sodium with normal osmolality, what is called pseudo-hyponatremia, because of high lipids or high proteins in the blood, like in multiple myeloma, Waldenstrom's macroglobulinemia, all paraproteinemias, or in severe hypertriglyceridemia because of relatively larger portion of plasma volume being occupied by these substances other than sodium. And there is another entity which is much more common called isotonic or hypertonic hyponatremia due to solutes other than sodium in plasma, like glucose and mannitol drawing out water from the intracellular fluid. This is a common scenario where in a patient of hyperosmolar non-ketotic coma or in diabetic ketoacidosis, when the sugars are very high, you have an artifactually low sodium in the plasma because of drawing of water from the intracellular compartment to extracellular by the osmoles, which are other than sodium, that is glucose. So this is called translocational hyponatremia. Here we actually have to correct the serum sodium by adding 2.4 millimole per liter for each 100 milligram of deciliter elevation of glucose. For instance, if the patient's sugar is 600, so 500 more than 100, so 5 into 2.4, that is 12. So if the patient's measured sodium is 125, the actual sodium will be 137. So that we will not wrongly diagnose this patient as hyponatremia. So it is a hypoosmolality, not hyponatremia, that causes clinical consequence of cerebral edema. So hyponatremia in isoosmolar and hyperosmolar states, as I told you, with either paraproteinemias or because of hyperglycemia, is just a lab value and not clinically significant. So clinical features of hyponatremia are mainly because of hypoosmolarity, and they are much more prominent if the patient has acute hyponatremia, that is less than 48 hours. It depends on the magnitude and rapidity of fall of serum sodium, predominantly caused by cerebral edema. Most features, therefore, are neurologic. Nausea and malaise will start when the sodium is 125 or less, and headache, lethargy, confusion, and obtundation follow. And if the sodium reaches to 115 or less, then it supervenes stupor, seizures, and coma. If untreated, cerebral edema can cause a transtentorial herniation and death. That's why it's very, very important that acute hyponatremia has to be given an emergency treatment. This cartoon shows clearly how do we assess hyponatremia based on the severity. On one side, more severe, and the other side is less severe. Onset, rapid versus slow, because as the onset is, the duration of hyponatremia is more, the adaptive capacity of the body or the brain to hyponatremia increases. So the risk of developing the neurological complications come down in chronic hyponatremia as the adaptive capacity is high. So in acute hyponatremia with severe hyponatremia, you will have significant coma and seizures. Whereas in chronic hyponatremia, where the adaptive mechanisms have taken place, there may not be any symptoms or very subtle symptoms. Why it's important is because when there is a rapid onset of acute hyponatremia, there is a rapid decrease of plasma sodium concentration. Because of that, there is a low osmolarity in the blood. Because of that, the water will move from the extracellular to the intracellular compartment into the brain, causing cerebral edema. So how the brain protects against it is by these osmotic adaptive mechanisms. As soon as the water gain starts, the brain starts throwing out some of the molecules which are called idiogenic osmoles, myoinositol, taurine, and glutamate, or some of them. Along with it, the water also will be thrown out. This is the major adaptive mechanism by which the brain prevents itself from getting swelling and comes back to the normal osmotic state. So that is why when the hyponatremia crosses 48 or 72 hours, that is what is called chronic hyponatremia, the patient may not have the features of acute hyponatremia. The symptoms may be milder or asymptomatic due to this cerebral adaptation, but there may be subtle symptoms like headaches, nausea, mood disturbances, depression, difficulty in concentration, slow reaction times, and especially in elderly subjects, unsteady gait and frequent falls are one of the major symptoms of chronic hyponatremia. In the outpatient setting also, we can diagnose it. So in such setting, we always should check for serum sodium. Association with bone loss in animal studies as well as human data has been shown, because chronic hyponatremia is one of the major risk factors for osteoporosis, and low extracellular sodium increases osteoclastic activity. So combined with the tendency to fall, if the osteoporosis also is a major risk factor, these elderly subjects are more prone to fractures. So how to evaluate? As I already told you, serum sodium and water relationship is the one which determines how hyponatremia supervenes, because plasma sodium is equal to total body sodium plus potassium divided by total body water. So as the total body water increases in the denominator, the plasma sodium falls. That's why it is very important to remember that hyponatremia should be understood as a disorder of relative water excess than sodium deficiency. If this is understood, then the residents can be easily taught to manage the different causes of hyponatremia rather than pumping hypertonic saline into every patient of hyponatremia, including patients of congestive cardiac failure who are already volume overloaded. So classification of hyponatremia, that's why, is according to the extracellular volume status, where we can classify them into euvolemic, hypovolemic, or hypervolemic based on simple clinical criteria. In hypovolemic hyponatremia, what happens is the total body water is low, total body sodium is also low, but relatively the sodium is much lower than the water. In euvolemic hyponatremia, what happens is total body water is increased, but the total body sodium is normal. But because of this water excess, what is called dilutional hyponatremia, these patients are hyponatremic. In hypervolemic hyponatremia, what happens is there is a retention of both sodium as well as water, but the water excess is much more than sodium. So there again, there is a relative water excess. So if you look at this, in all these conditions, there is a relative water excess compared to sodium, whether it is on one side depletional hyponatremia or the dilutional hyponatremia. These two, euvolemic and hypervolemic, are called dilutional hyponatremia, where the water excess determines the sodium low. So if you understand this, then it is very easy to find out the etiology. In depletional hyponatremia, the etiology can be renal loss of sodium with water retention because of the compensatory ADH mechanism due to the hemodynamic stimuli, appropriate stimuli to ADH, or the loss of sodium can be through extra-renal routes. The renal loss of sodium can be because of diuretics. The commonest example of thiazide diuretics, especially in elderly subjects. It can be because of mineralocorticoid deficiency, like in Addison's disease, salt wasting nephropathy, diabetic ketoacidosis, glycosuria, and a rare condition called cerebral salt wasting syndrome in many acute neurological syndromes like head injury or subarachnoid hemorrhage. Or the loss of sodium can be extra-renal, like GI losses, vomiting, diarrhea, third space losses like muscle trauma, burns, pancreatitis, GI obstruction, sweat losses like endurance exercise, like a marathon runner. If he loses a lot of water and sodium through sweat, but takes only glucose-containing liquids and not supplementing with sodium, then they can have hyponatremia. So dilutional or euvolemic and hypervolemic hyponatremia can be again because of impaired renal free water excretion. That is the commonest cause, where SAADH, various etiologies will come in, along with glucocorticoid deficiency, hypothyroidism. And hypervolemic hyponatremia, where there are edematous states like congestive cardiac failure, cirrhosis, nephrotic syndrome, and renal failure, both acute and chronic. Rarely, hyponatremia due to dilution can be because of excessive water intake, like in psychiatric patients where they ingest a lot of water, primary polydipsia, or as I already told you, exercise and marathon associated, where you drink a lot of water after an exercise without supplementing sodium appropriately, and rarely dilute infant formulas and fresh water drowning. These are the causes. These we don't see very commonly. You just look at, these are the things, euvolemic and hypervolemic hyponatremia, which is important as causes of dilutional hyponatremia. So once we know this, assess the volume status. If the patient is hypovolemic, euvolemic, or hypervolemic, and get two simple tests. One simple test, urine sodium. If the urine sodium is more than 20, it means that the losses are occurring from the kidney, renal losses, commonest being thiazide diuretics. If the urine sodium is less than 20 in a patient who is depletional hyponatremia, it means the causes are extra-renal, because the body tries to conserve the sodium by the renin-angiotensin system stimulation, and the urine sodium is less. If the volume status is euvolemic, no edema, total body water is increased, total body sodium is normal, then you again see urine sodium more than 20. The commonest causes will be SAADH caused by drugs or stress, or glucocorticoid deficiency and hypothyroidism. If there is a hypervolemic hyponatremia and the urine sodium is more than 20, then the causes are in the kidney, acute or chronic renal failure. And if the urine sodium is less than 20, then this can be any of the edematous states like CHF, cirrhosis, or nephrotic syndrome, where clinically it will be evident that the patient has edema. So summarizing, in a patient of hyponatremia, first exclude hyperglycemia and other causes of non-hypotonic hyponatremia. Confirm that it is hypotonic hyponatremia. Whether the patient has acute or severe symptoms, as I already told you, yes, then consider immediate treatment with hypertonic saline. I'll tell you how to do it in the subsequent slides on treatment. But if the patient is not acutely symptomatic and there are no severe symptoms, it could be a subacute or chronic hyponatremia, then go for further investigations. Urine osmolality is the major investigation. If the urine osmolality is low in a patient of hyponatremia, then you are dealing with a patient who is drinking a lot of water, primary polydipsia. If the urine osmolality is more than 100 in a patient of hyponatremia, which is what commonly we see, because these patients are losing more sodium than free water, they're retaining free water, then as I already told you, the urine sodium will give you the further clues. If the urine sodium is less than 30 with an effective intravascular volume being low, then depending upon whether their extracellular fluid volume is contracted, it can be a depletional hyponatremia. If the extracellular fluid volume is expanded, if they have edematous state, then it can be a dilutional hyponatremia. If the urine sodium is more than 30, then this history, repeatedly you ask, many times this history may not be forthcoming, whether the patient has been taking any diuretics, commonly thiazide diuretics, and many times we find that the patient is on some antihypertensive where thiazide is added in a fixed dose combination. They really don't come out with that history. And if you carefully look at all the drugs, the patient is on thiazide. Once you stop it, the hyponatremia reverses. If the patient is not on diuretics and still having low sodium with increase in urinary sodium, then it can be any of the causes which causes increase in renal sodium wasting. Like if the volume is contracted, then it can be all the renal salt wasting syndromes. If the extracellular volume is normal, then the commonest cause in this is SAADH. So SAADH basically is a decreased effective plasma osmolality, that is less than 275, where inappropriately the urine osmolality will be more, that the urine is being concentrated more because of excessive ADH action. So the urine osmolality will be more than 100 in the face of hypoosmolality of the blood. Clinical euvolemia, there will be no signs of depletion or overload. Urine sodium more than 40, normal thyroid and adrenal function, and no recent diuretic use. There are some supplemental features where if you have difficulty in differentiating it from depletional hyponatremia, we look at plasma uric acid, the blood urea and nitrogen levels, both will be low in patients of SAADH. I'll tell you subsequent investigations, maybe we can take up during the discussion. SAADH is one of the commonest causes of both acute as well as chronic hyponatremia because it can occur in several malignancies where it's a paraneoplastic syndrome. It can be non-malignant inflammatory pulmonary disorders like in several forms of bronchitis, asthma, or in ICU patients, or CNS disorders, both acute and chronic because of infection, inflammation, or ischemic insult, or other factors like most important will be the drugs. There are several drugs which act on the CNS, especially the antipsychotics, antidepressants, many anticonvulsants, the commonest being the carbamazepine and tricyclic antidepressants. These are the major causes of SAADH. So in a patient of hyponatremia, this history is very, very important, whether the patient has any drug which causes SAADH. So how do you evaluate? The most important things in the history and physical examination will be to look for hypovolemia, whether there is history of vomiting, diuretic use, diarrhea, and on examination, JVP, skin turgor, hypotension, postural, or otherwise. This is very important to find out whether there is the major factor is a depletional hyponatremia. Or hypervolemia features like signs of peripheral edema and or ascites for congestive cardiac failure or cirrhosis of liver respectively, and signs and symptoms of hypothyroidism and adrenal insufficiency, and pointers to etiologies of SAADH in the different systems, especially the pulmonary and the central nervous system. As I told you, the key lab investigations in our algorithm will be the serum osmolality, urine osmolality, and spot urine sodium concentration. And others, serum uric acid and urea, potassium and acid-base balance, thyroid function, serum cortisol, and fractional excretion of sodium, as the case may be whenever it is required. As I already told you, fractional excretion of uric acid and fractional excretion of urea have been used whenever there is a doubt in diagnosing SAADH because these have better sensitivity and specificity for diagnosis of SAADH. Recently, another molecule which has come up is what is called plasma copeptin. Just like insulin is co-secreted along with the C-peptide, and C-peptide is a marker, stable marker of insulin levels in the blood. Plasma copeptin levels are stable surrogate for AVP levels. And copeptin has been used in hyponatremia to differentiate between primary polydipsia and other causes of hypovolemic hyponatremia, because in hypovolemic hyponatremia, you get maximum levels of the copeptin. In other etiologies of hyponatremia, copeptin levels may overlap widely, thereby limiting its use in the differential diagnosis. In our patient, 48 hours post-pituitary surgery, the serum sodium was 128, urine sodium was 46, plasma osmolarity was 275, urine osmolarity was 230. So the patient was hypoosmolar. At the same time, the urine was getting concentrated and more urine sodium. BP was 130/80, no postural fall. So there were meaning there was no hypovolemia. Hydration status was clinically normal. Morning serum cortisol was 30, appropriate for stress. Free T3, free T4 were normal. So the diagnosis in this setting with all these biochemical criteria is clearly a syndrome of inappropriate ADH secretion. But many times neurosurgeon ask us whether it could be another entity called cerebral salt wasting syndrome. Compared to SADH, this is a much rarer entity which has been described in most acute neurologic insults like subarachnoid hemorrhage or postoperative because of secretion of mediators from the brain like ANP and brain natriuretic peptide and also renal sympathetic activation. There is a salt wastage from the kidney, but it has been shown that it's not as common as SADH in many series. There are only few case reports of real proven cerebral salt wasting syndrome. How do you differentiate between SADH and cerebral salt wasting syndrome? In both, the sodium will be low, but urea will be increased in cerebral salt wasting syndrome because it's a volume contracted state. The blood pressure will be normal in SADH, whereas there can be a postural fall or actual low BP in cerebral salt wasting syndrome. The urine volume may be low, will be high in cerebral salt wasting syndrome, and urine sodium will be raised in both, but CVP will be low in cerebral salt wasting syndrome. So the key to diagnosis of cerebral salt wasting is the demonstration of intravascular volume contraction. We already said about the algorithm, but we patients don't read textbooks, and each patient may suffer from more than one disease. So these algorithms are only guidelines. So our clinical acumen is paramount. Diuretics can complicate picture by increasing urine sodium. Fractional uric acid excretion can be useful in such patients. Spot urine sodium is not always accurate. There is a gray area between 20 to 40. And mild hypovolemia may be difficult to differentiate from euvolemia. And multiple causes can coexist in the same patient. For instance, in the ICU, a patient of pneumonia can have SADH because of pneumonia. At the same time, he may be on diuretics for congestive cardiac failure and also having vomiting, so causing depletional hyponatremia. So same patient, 3 factors may be there. So how do you treat? Is hyponatremia severe? Yes, and if symptoms are also severe, then straight away you find out what is the duration. If it is acute hyponatremia less than 48 hours, whenever in doubt, we always treat on the side of under treatment, except if the patient is throwing a fit. Any unknown duration should be treated as chronic hyponatremia. Acute hyponatremia less than 48 hours, emergency correction with hypertonic 3% saline, 1 to 2 ml per kilogram per hour until safe targets are met. If it is chronic, then the rate of correction has to be slower. We try to do it first with just a 0.9% saline and give a therapeutic test. If it doesn't improve, then 3% saline until symptoms resolve with 1 ml per kilogram per hour, and then correct with 0.5 millimole per liter hourly with 0.9% saline only. If it is chronic and no significant symptoms are there, urgent intervention is unnecessary. So assess the extracellular volume status and correct the sodium at hourly rate of only 0.5 millimole per liter. So if the extracellular volume status is contracted, you are clearly dealing with a case of depletional hyponatremia. Discontinue the offending agent like diuretics, and you can restore the intravascular volume with just IV normal saline. Here you need not give 3% saline. Oral salt and water if the patient is taking adequately orally. If the patient's ECF status is normal or near normal, rule out hypothyroidism and hypoadrenalism. Discontinue offending drugs which can cause SADH if possible. Restrict fluids to 750 to 1000 ml per day. This is difficult to do, but this is one of the things we first do. Give more oral salt, and then we can try agents which can counter SADH. Like earlier, demiclocycline was tried. Now we have 2 agents, urea and AVP antagonists, which are the Vaptans. If the volume is expanded, that is CCF or cirrhosis of liver, optimized treatment of underlying cause, salt and water restriction, loop diuretics, and AVP antagonists again have been used. So if you look at it, both in normovolemic and hypervolemic hyponatremia, AVP antagonists have been used, but never in depletional hyponatremia. In depletional hyponatremia, you have to just correct the intravascular volume. In acute hyponatremia, don't immediately aim for a normal sodium. You aim for an initial target sodium of 120 to 125 only. Use 3% saline. Correction rate, do not exceed 12 millimole per liter in 24 hours in acute hyponatremia. Do not use isotonic saline except as a therapeutic test. And along with this, you can use furosemide 20 to 40 milligram IV to promote free water loss in patients who are not depletional hyponatremia. There are two major guidelines which have come in the last few years, in 2-3 years, the European versus US guideline. In US guideline, in acute hyponatremia, they advise to give bolus of 3% sodium chloride, 100 ml over 10 minutes, 3 boluses as needed if there are severe symptoms. Whereas in European guideline, they say bolus of 3% saline, 150 ml over 20 minutes, 2 to 3 times. If the symptoms are moderate, then you can give a continuous infusion of 3% saline at the rate of 0.5 to 2 ml per kilogram per hour, which can raise the serum sodium by 0.5 to 2 milliequivalent per hour. But this is not indefinitely. You are supposed to keep monitoring. In chronic hyponatremia, fluid restriction will be the first line. In US guidelines for SAIDH, they suggest democlocycline, urea, or Vaptans as second line. In hypovolemic hyponatremia, as I already told you, isotonic saline. In hypervolemic hyponatremia, fluid restriction and Vaptans are advised in US guideline. Whereas in the European guidelines, it strongly advises against use of Vaptans for any form of hyponatremia, whether it is SAIDH or hypervolemic hyponatremia. And instead, they are advising more of fluid restriction, urea or loop diuretics plus oral sodium chloride for chronic SAIDH. And isotonic saline or Barron's crystalloid, if it is hypovolemic, there is no doubt in this. And in hypervolemic hyponatremia, only fluid restriction and loop diuretics are used, and there is a clear no for the use of Vaptans. So the US and European guidelines differ as far as use of different agents for hyponatremia. As I told you already, the correction rates in both acute and chronic hyponatremia vary. In US guidelines, it is more conservative because you want to avoid the complication of overcorrection. So you give 4 to 8 millimole per liter per day even in acute hyponatremia. Do not exceed 12 millimole per liter any day at any circumstance. And in patients who are at a high risk of osmotic demyelination syndrome, where the patients are already alcoholic or having liver disease or having severe hyponatremia, aim for a correction of only 8 millimole per liter per day in first 24 hours to 48 hours. Management of overcorrection is one thing which we do nowadays, where if the baseline sodium is more than 120, it's not necessary. But if the baseline sodium is less than 120, in some centers, what they do is, in addition to giving 3% saline or a Vaptan, they start re-lowering with electrolyte-free water or desmopressin after the correction exceeds 6 to 8 millimole per liter per day, so that you avoid overcorrection and the consequence of overcorrection, which is called osmotic demyelination syndrome. As I already told you, the sodium correction should be first 1 to 2. In the first 3-4 hours, you can raise it by 1 to 2 millimole per liter per hour, because cerebral edema can be minimized by just raising the serum sodium by 4 milliequivalents per liter. That's enough. Subsequently, in the 24 hours, you do not exceed 12 millimole per liter at any cost. And in 48 hours, do not exceed by 18 millimole per liter. And whenever we are correcting the hyponatremia due to depletional cause, even by giving normal saline, there can be what is called an auto correction once the volume depletion occurs. So you have to be monitoring these patients much more carefully. So I'll tell you how frequently you have to monitor subsequently. In chronic hyponatremia, do not raise it more than 0.5 to 1 millimole per liter in the first few hours. except in severe symptoms, and never exceed more than 8 in 24 hours. Why this is so is because when there is a rapid correction of chronic hyponatremia, as I already told you, the idiogenic osmoles which are released by the brain, they will cause rapid increase in plasma. When the plasma sodium concentration is rapidly raised, instead of the water comes out of the intracellular compartment into the extracellular compartment faster, causing a cerebral cell dehydration, causing an osmotic demyelination syndrome. This constitutes what is called a central pontine myelinolysis, which is a common consequence of rapid treatment of hyponatremia. So when you compare the different modes of therapy, I'll just summarize this and then I'll end with the note on the Vaptans and urea, then we can have discussion. Fluid restriction is inexpensive, but the problems are very difficult to ensure compliance and it has moderate efficacy. Hypertonic saline is effective, but you have to be careful rather than doing overcorrection. Loop diuretics are effective in correcting volume overload, but they are mostly used in volume overloaded states. They have the risk of causing electrolyte imbalance like hypokalemia. Demiclocycline has largely been given up because of nephrotoxicity. Lithium, again, we hardly use because of its adverse effects. Urea and Vaptans are the two agents which have been now suggested to be useful in hyponatremia, in chronic hyponatremia especially. But urea has unpleasant taste and we have limited experience. We don't have urea available in our country. Vaptans, because of their targeted physiological action and quite good effectiveness, these are the advantages, but the problems will be the risks of overcorrection. And there are reports of hepatotoxicity when Vaptans were used in higher dose, especially in patients of autosomal dominant polycystic kidney disease, and uncertainty regarding the long-term effects of Vaptans. What is the duration for which they can be used in chronic hyponatremia? That again is questionable. But as I have already told you, AVP plays a role in all the forms of hyponatremia, whether it is a physiologic AVP secretion in response to volume depletion or the effective intravascular volume contraction in volume overloaded states, or as an SAADH in inappropriate AVP secretion. So in all the three forms of hyponatremia, AVP plays a role, even though differently. But Vaptans, as I told you, have been approved for use only in two forms of hyponatremia, that is hypervolemic and euvolemic hyponatremia due to SAADH. One meta-analysis showed improved survival, but we don't have randomized control trials or comparison of different Vaptans across head-to-head comparison. Real-life experience of tolvaptan says that even though the overcorrection more than 12 was there in 25% of cases, but no case of osmotic demyelination was reported. So this is a welcome finding from one study. Symptoms improvement in neurocognitive performance status in cancer patients, dyspnea in congestive cardiac failure, and ascites in cirrhosis have been shown. But in chronic hyponatremia, whether it really improves the cognition, whether it improves the frequency of falls, or whether it improves bone density, these are the things which have to be studied. Urea is an interesting agent which has been mainly talked about in European guidelines because there is an interesting correlate that patients with end-stage renal disease are resistant to osmotic demyelination syndrome, and urea is neuroprotective. But the main problem in giving urea is the palatability. It has been taken care of by formulation with soda bicarb, citric acid, and sucrose. Commercially available urea preparations now are there. There is one formula called Nefcentric. It's available through Amazon. Some people have got it and they've used, but I have not used urea in my experience. Neurologists are very fond of using urea in their patients of hyponatremia. So many times you ask, how do you calculate the saline infusion rate? There is a very complicated formula given. This is what is called the Adrog-Medius formula in this famous article 20 years ago in New England Journal of Medicine. But I will not go into this. There is a simple rule of the thumb which we follow is multiply patient's body weight by the desired rate of correction of sodium per hour to get the hourly infusion rate of 3% saline. For instance, in a 60 kilogram patient, to get 1 millimole per hour rise in serum sodium, you infuse 60 into 1. That is 60 ml of 3% saline per hour. If you want a faster correction, you want to raise by 2 millimole per liter per hour, then multiply by 2, that is 120 ml per hour. If you want a more slow correction like in chronic hyponatremia, then 0.5 millimole per liter, so only 30 ml per hour. But unfortunately, in many of our hospital setups, the hyponatremia correction with 3% saline is done routinely, but at much lower values of 5 ml, 10 ml per hour, continuously going on without actually looking for the sodium correction. So the monitoring of serum sodium has to be very frequent on 3% saline every 2 to 4 hours. If the patient is on AVP antagonist, every 6 to 8 hours in the first 48 hours. And once you stop 3% saline and Vaptans, once the symptoms have abated, serum sodium is more than 120 and a safe rate of correction has been achieved. And patients with stable levels on fluid restriction plus oral salt, they can be monitored daily till they are discharged, and subsequently they can be monitored maybe weekly if they are chronic hyponatremia on OPD follow-up. There are several questions in this area. Can Vaptans replace hypertonic saline in acute hyponatremia? Many guidelines say no. Duration of treatment, again, it's a big question mark. The authority on this subject, Professor Verbalis, said that he has used in many of his patients for quite a long time. Long-term outcome data are awaited, like maintenance of serum sodium, what are the neurocognitive outcomes and functional status, whether they improve outcomes in congestive cardiac failure, liver disease. Till now, the studies have shown they really do not improve outcomes. Effect on bone mineral density is another interesting thing to be studied. And more widespread use of urea has to be also encouraged, because this seems to be another good molecule for chronic hyponatremia. Thank you, one and all, for the patient hearing.
Thank you, Dr. Muralidharan. That was quite exhaustive and practical as well, as expected. We'll take the questions at the end. Let's go over to Professor Rakesh Sahai. So we look at the other end. If you would stop sharing your slides, and Dr. Sahai can come in with his slides. So we talked of sodium hyponatremia, which is the major extracellular ion cation. And now we go over to potassium, which is the major intracellular cation. And to take us through this journey, we have Professor Rakesh Sahai, and he will talk on implications and investigations of hypokalemia. So over to you, Rakesh. And again, try and be as close to 20 minutes as possible, but I do understand these are all vast topics to deal with.
Thank you, sir. Thank you, sir. Good evening to all of you who have joined in today evening. And after the very good and exhaustive discussion we had on hyponatremia, I would try to quickly cover about hypokalemia, discussing mostly about the implications and the investigation of hypokalemia. So hypokalemia is an equally important problem which is commonly seen, electrolyte disturbance which is commonly seen. It's very common in hospitalized setting, and we could say that 21% of all hospitalized patients will have a serum potassium less than 3.5 and at some point of time or the other, and up to 5% of them also have very severe hypokalemia, and this is more commonly in the elderly patients, and particularly in the outpatient setting also, it is quite common in patients taking non-potassium sparing diuretics, and in this setting, almost 20 to 50% develop hypokalemia. So hypokalemia is a common problem. We are likely to face this, see this very commonly in both in outpatient setting and in the inpatient setting, and it's important to understand that just to get through some basics about potassium. It's the predominant intracellular cation, and it is very essential for the functioning of all the living cells. And while the intracellular concentration is about 150 milliequivalents per liter, in the extracellular fluid compartment, the concentration is very closely regulated between 3.5 to 5 milliequivalents. So there's almost a 30 times higher concentration maintained intracellularly, and this is and the serum sodium level is closely regulated by the intake, the excretion, and the transcellular distribution. So these are the three major factors which are regulating that, and most of the total body potassium is present in the muscles, the liver, and erythrocytes, and the bone, which each of these contain about 7% of the potassium. And aldosterone is the major regulator of the sodium, the potassium excretion, the renal excretion of potassium. So as I mentioned, that 98% is intracellular, and only 2% is in the extracellular compartment. And what is happening is that the major regulation of potassium is through the excretion, which is happening. 90% is happening through the urine, and 10% is through the stools. And the major buffering, cellular buffering, is the immediate defense mechanism, and the renal regulation is the long-term strategy for maintaining the potassium levels. So this is how potassium is regulated. And if you're looking at the factors which influence the movement of potassium from the extracellular fluid to the intracellular compartment, are mainly insulin, the catecholamines, which are working through the sodium potassium ATPase pump. Then the tonicity of the extracellular fluid also is another factor. The pH is another factor. At a when the pH is going down towards acidosis, you have the shift out of the cells, whereas in alkalosis they shift into the cells. And then sodium potassium ATPase is the pump that maintains the high intracellular potassium level, and it's stimulated by insulin, beta adrenergic receptors, and the extracellular potassium concentration. So these are the major factors regulating the transcellular shifting of potassium. So as you can see here, if you look at in summary, there are about 100 milliequivalents of potassium is taken in every day, and this is the excretion is again 100 milliequivalents, 90 coming through the urinary excretion, and 10 milliequivalents coming out to the fecal excretion. And as I mentioned here, that we are looking at the various factors which I've already discussed just now. And so the rate of potassium intake, which is 100 milliequivalents per day, is matched by the urinary excretion of 90 milliequivalents and the fecal excretion of 10 milliequivalents every day. And if you look at the renal potassium handling, what we see is that potassium is filtered through the glomerulus and it's almost completely absorbed before reaching the collecting duct. About 65% is reabsorbed in the proximal tubule and 25% in the loop of Henle. 10% actually reaches the distal convoluted tubule. It is important to note that almost all the potassium in the urine is secreted by the collecting ducts. So most of it gets reabsorbed, and what is coming out in the urine is what is secreted by the collecting ducts. And this contains the collecting duct, as we know, contains two types of cells: the principal cells, which reabsorb which primarily reabsorb sodium and secrete potassium under the effect of aldosterone, and the intercalated cells, which maintain the acid-base balance. And the number of intercalated cells declines as the collecting duct slopes towards the medulla. So this is how the handling of potassium goes on. As I was mentioning, in the distal convoluted tubule, in the first part of the distal convoluted tubule, we are looking at the sodium chloride co-transporter. And as we go down towards the later part of the distal convoluted tubule and the collecting ducts, we see that we have the ENaC channels, which are which are playing an important role in terms of sodium reabsorption and potassium being put out in exchange for the sodium. And then we have in the collecting ducts, we have again the ENaC channels, the renal outer medullary potassium channels, and so these are the ones which regulate the potassium loss. Now the renin-angiotensin-aldosterone system is a major system which regulates the potassium loss in the urine. As we have said, that you could have factors which interfere with the release of renin. NSAIDs, beta blockers, cyclosporin, tacrolimus, and also in diabetes, long-standing diabetes, you could have impairment of release of renin, and this could lead to hypokalemia through this mechanism. Then you have direct renin inhibitors which are acting here. Then you have the angiotensin converting enzyme inhibitors which are acting which are preventing the conversion of angiotensin 1 to 2. And then we have the angiotensin receptor blockers, which are acting at the site of action of the angiotensin 2. And Finally, we have aldosterone, which is responsible for the sodium reabsorption and the potassium loss. So if you look at the causes of hypokalemia, we can say that inadequate intake could be a cause in patients who are dementic, who are not taking enough intake. Anorexia can be a factor, starvation, total parental nutrition, those on total parental nutrition. In all these situations, inadequate potassium intake could be a factor causing the hypokalemia. Then there could be a lot of medications which could be contributing to hypokalemia, as we discussed just now. We have the diuretics, particularly causing hypokalemia. The laxatives and enemas can cause GI losses of potassium. Then corticosteroids and insulin and decongestive syrups, which have alpha-2 adrenergic activity, and verapamil. These are all the factors which can cause hypokalemia. These are all the medications which can contribute to hypokalemia. Then we could have abnormal losses, the GI losses, which could be contributing to that. Apart from the GI losses, can also be because of dialysis-induced hypokalemia. Osmotic diuresis can be contributing to hypokalemia. Then states of mineralocorticoid excess, and then type 1 and 2 renal tubular acidosis and polydipsia. And transcellular shifts also can be an important factor contributing to hypokalemia, as can happen with the correction of acidosis in various settings, and refeeding syndromes, and increased beta-2 adrenergic stimulation that is happening with head injury or in a patient who has a MI. This could be a factor which is contributing to hypokalemia. And then thyrotoxicosis, as we all know, is another situation where there's increased beta-2 adrenergic activity, and that can contribute to hypokalemia. Then pseudo-hypokalemia, but whenever we are diagnosing, we are picking up hypokalemia, we need to exclude pseudo-hypokalemia. One of the situations where it happens is in the presence of extreme leukocytosis, where there is delay in sample analysis, so the leukocytes consume the potassium, and this can lead to a lower potassium level. So the solution to that is to process the sample faster so that we don't have this sort of an error. Now, when you look at various drugs causing that interfere with the renin-angiotensin system, which can contribute to the problem, are we have the risk factors which can. These are all the situations where the drugs that can influence the potassium loss and can contribute to hypokalemia, chronic kidney disease, diabetes mellitus, decompensated congestive heart failure, volume depletion, advanced stage, as we said, and the drugs that we discussed about can all contribute to, can influence the effect of the RAS system and contribute to hypokalemia. So now looking at the classification of hypokalemia, we can say that as we know that 3.5 to 5 is what we're looking at as the normal concentration of serum concentration of the potassium, and mild hypokalemia would be in the range of 3 to 3.5, moderate in the range of 2.5 to 2.9, and less than 2.5 is very severe hypokalemia. So if you look at as a severity, with mild hypokalemia, the patient may be absolutely asymptomatic or may have very mild symptoms, especially in the elderly people. On people suffering from heart or kidney disease, they may have mild symptoms, they may have weakness, and they may have fatigability. Whereas with more severe hypokalemia, you could have various other manifestations. The neurological manifestations are very prominent: leg cramps, weakness, and paresis. Ascending paralysis is very commonly seen in patients presenting with very severe hypokalemia with sudden onset. Then there could be gastrointestinal symptoms in the form of paralytic ileus or bloating, abdominal bloating, and all these features can be seen. On the renal system, you could see that there is rhabdomyolysis could be a factor which can be which could be a factor be seen in severe hypokalemia. Then cardiovascular effects like changes in the ECG, you could see U waves coming up, T wave flattening, ST segment changes can be seen, and hypokalemia, severe hypokalemia could precipitate cardiac arrhythmias and could also precipitate heart failure. So if you look at the management of hypokalemia, what we are looking at is initially is to come to a conclusion as what is the cause for the hypokalemia, so that we can appropriately manage that accordingly. So the first step would be to check the magnesium level. If the magnesium is low, then replace the magnesium level, because that could be a factor contributing to the hypokalemia in some situations. And so this is an important test that needs to be done at in any patient who has hypokalemia. And then you look at the renal excretion of potassium to identify whether this is a renal loss or this is a non-renal loss of potassium. So those who, we could have when the renal 24-hour urine potassium is less than 30 milliequivalents, or the urine potassium creatinine ratio is less than 1.5 millimoles per 1.5, then that is a situation where you're suspecting a GI loss, or you're suspecting transcellular shift of potassium because of insulin, or because of beta-2 adrenergic activity, or because of diuretics, and these are situations where you need to avoid these. While if you're looking at a 24-hour urine potassium being more than 30 milliequivalents, or the ratio again between the urine potassium to creatinine ratio being more than 1.5, then this is suggestive of a renal loss of potassium. Now, again, there could be fallacies in measuring the 24-hour urinary potassium, or in terms of looking at the ratio, because there could be different factors in those who have a lower GFR, and there could be other factors playing a role. So in all these situations, you can look at calculating the TTKG, and a TTKG of more than 3 would suggest renal cause. So this confirms a renal cause, and this is helpful in overcoming all these fallacies in terms of measuring of the urinary potassium. So once we're looking at a renal loss, then what we look at is the blood pressure. The next parameter that we need to assess is whether the patient has got a normal blood pressure or has got a high blood pressure. If he has got a high blood pressure, then you know that it could be because of you could be dealing with a situation where there is a high plasma renin activity with high aldosterone levels, and this is the setting seen in malignant hypertension, renovascular hypertension, and a renin secreting tumor. So these are situations where there is high renin activity with high aldosterone level. So the problem is starting at the level of the high renin level. So this is a feature of malignant hypertension, renovascular hypertension, and renin secreting tumors. When you're dealing with a situation where the plasma renin activity is low, but you have a high aldosterone level, this is a situation of this is the situation seen in primary aldosteronism. And when you have a low plasma renin activity with low aldosterone concentration, then you need to suspect Cushing syndrome, congenital adrenal hyperplasia, or say mineralocorticoid intake, or Liddle syndrome. So these are the conditions that you need to look at when you're dealing with a low plasma renin activity with low aldosterone levels. In patients with a normal blood pressure, we need to look at the bicarbonate in the serum bicarbonate levels and the urinary chloride levels. Low bicarbonate suggests renal tubular acidosis, and when you have a low bicarbonate with and when you have a high bicarbonate level in the blood with a urinary chloride level of less than 10 milliequivalents per day, this is suggestive of the scenario of vomitings. Whereas if you've got a high bicarbonate with urinary chloride excretion of more than 10 milliequivalents per day, then this is the scenario produced by diuretics, use of diuretics, or in hypomagnesemia, or because of Barter's syndrome or Gitelman syndrome. So these are the situations that you need to look at when you're dealing with a high serum bicarbonate with increased urinary chloride excretion, more than 10 milliequivalents per day. So the treatment would be based on what we're dealing with. We would treat them appropriately. So drug screen, the additional investigations which are based on the suspected diagnosis include a drug screen in urine and serum for diuretics, amphetamines, or other sympathetic mimetic stimulants, serum renin, aldosterone, and cortisol levels, in the appropriate scenarios, and 24-hour urinary aldosterone, cortisol, sodium, and potassium. And these are the appropriate things you do in the scenarios as we've just discussed. Pituitary imaging to evaluate for Cushing's syndrome, adrenal imaging to evaluate for adenoma. So these are all the situations that we may need to look for. Enzyme assay for 17-beta hydroxylase activity may be required, and thyroid function studies in patients who present with typically with tachycardia and have features of thyrotoxicosis, we may have to assess for thyroid functions. So why do we need to intervene in patients who present with hypokalemia? We have looked at the manifestations, we have seen how to evaluate for them, and we know that with long-standing hypokalemia, uncorrected hypokalemia can have significant impact on the on not only the neurological manifestation, can lead to a lot of neurological manifestation, but can also have increase the cardiovascular morbidity and mortality. And so therefore, it is very imperative that hypokalemia has to be corrected rapidly. And the treatment of hypokalemia has 4 facets as follows. One is to reduce the potassium losses, then to replenish the potassium stores, and then you need to evaluate for potential toxicities and determine the cause to prevent future episodes if possible. So these are the 3 facets of treatment. When you're looking at reducing the potassium losses, you need to look at the diuretic use of laxatives, which are contributing to the losses, either the renal losses or GI losses. Use potassium sparing diuretics if diuretic therapy is required in patients with severe heart failure. Treat diarrhea and vomitings, and administer H2 blockers to patients receiving nasogastric suction. So these measures could prevent the losses, renal and GI losses of potassium. And controlling the hyperglycemia is also very important, because that can also contribute to the excess potassium loss. Then replenishing the stores. For replenishing the potassium stores, for every to increase the potassium levels by 1 milliequivalent, you require to provide about 200 to 400 milliequivalents of potassium needs to be supplemented. Patients who have mild or moderate hypokalemia, only oral potassium replacement therapy is adequate. But those with severe hypokalemia, intravenous potassium should be given. You need to maintain a close follow-up, and because the potassium infusion is associated with very rapid infusion can lead to arrhythmias, and from ECG monitoring has to be done when you're replacing the potassium, and we need to check this serially check the potassium levels. So we could do it with when looking at oral replacement. Potassium tablets are available or you could use potassium infusion. And the potassium tablets which you're speaking of is potassium chloride, and we have the different potassium salts available: potassium chloride, potassium bicarbonate, potassium citrate, then acetate, phosphate, and gluconate. These are the various preparations available, and the various indications. I mean, in the sense that when you're looking at supplementing patients with renal tubular acidosis or diarrhea, potassium bicarbonate could be a good choice. However, we should be careful that it can worsen the metabolic alkalosis. And so this table gives an illustration of the various different potassium preparations that are available, and the caveats for their use. Now, with regard to assessing for the potassium toxicity, monitoring of, we need to carefully monitor the cardiac, watch for cardiac arrhythmias when we're replacing potassium, because particularly when you're using parenteral therapy, when you're using IV infusions, then we need to be careful, and cardiac monitoring has to be done. And finally, for preventing the future episodes of hypokalemia, we need to determine the underlying cause of patient's hypokalemia and to treat the condition and prevent further episodes. Consider, and in some patients who have alcoholism or eating disorders, we need to take the help of psychiatrists. We need to tailor the individual treatment as per the individual patient. And we may require to take the services of a psychiatrist or dietitian when there is inadequate intake, or in situations like renal artery stenosis or adrenal adenoma or intestinal obstruction, we may need to go for a surgical cure for such situations. So finally, I would summarize by saying that hypokalemia is a very common inpatient, both in the inpatient and outpatient setting. The major regulator of potassium is the aldosterone, and intravenous. Hypokalemia should be evaluated properly to understand what is the cause of hypokalemia. And once we understand the cause of hypokalemia, the treatment can be appropriately directed. And oral treatment, oral potassium supplementation should be preferred wherever possible. Intravenous treatment is reserved for severe hypokalemia. And in such situations, we need to be careful while supplementing, while administering potassium intravenously. Potassium chloride is the preferred potassium salt for treatment of hypokalemia. Cause of hypokalemia is usually ascertained by obtaining a careful history, checking the BP, and ordering a few laboratory tests, as we have discussed just now. Distinguishing renal loss from GI loss of potassium is very essential, and we may need to involve other colleagues of ours to appropriately manage the hypokalemia. Thank you. Thank you all for the patient hearing.
Thank you, Professor Sahai, again for giving us a wonderful insight into hypokalemia and its the implications as well as the evaluation. So we have got quite a few questions in our chat box. I hope Dr. Muralidharan is still with us. So can we start with you, Dr. Muralidharan, with the questions? Right, great. So first question, maybe a couple of questions from my side as well. You did sort of mention the basic investigations required to evaluate for hyponatremia, which were not many actually. Apart from serum sodium, you had mentioned osmolality. So firstly, for measurement of sodium, there are two broad methods, the flame photometry, which is sort of an older method, and then the iron-specific electrodes. So is there a choice between the two?
Yeah, we prefer iron-specific electrode because that will obviate many problems with the flame photometry, especially the pseudo-hyponatremia due to hypertriglyceridemia and paraproteinemia can be obviated if you do an iron-specific electrode.
Right. The other investigation that you mentioned is osmolality. Now, this is thought to be best done on an osmometer by freezing point depression method. But maybe many different laboratories would not have it, and they do it by measuring sodium and potassium and calculated osmolality. So do you have major objections to that?
It's always better to do it by an osmometer with freezing point depression method, because there are, as I told you, the calculated osmolality can be erroneous because of non-sodium osmoles like mannitol or glucose. Plus, when we are, there are so many variables which interfere with the measurement. So in an ideal setting, we need an osmometer, but I understand there are many setups where because every patient of hyponatremia, if you use the formula to calculate osmolality, the osmolality will be low. We will not be able to differentiate the two rarer forms of isotonic and hypertonic hyponatremia by using the formula method. We'll be wrongly labeling everybody as hypotonic. So the ideal osmolality should be measured by an osmometer with freezing point depression. Then only we can differentiate between, but unfortunately in clinical scenarios, especially in a primary setting, it's not possible. So we go more by the setting of the patient. Like in a patient of uncontrolled hyperglycemia, even without doing osmolality, we know that the cause of low sodium is because of high glucose, and we correct appropriately as per the formula which I gave. So every patient of diabetic ketoacidosis and hyperosmolar state, when we see, we should always look at their sodium and correct it as per the glucose value.
Right. Another, I mean, this is also actually my question. It's been observed that in the context of acute hyponatremia, somehow premenopausal women suffer the most, maximum morbidity and mortality. Do you have any ideas as to what's there? Is it in the hormones? I mean, I don't have a clear answer, but that's a
One of the
observation.
hypotheses is that in an estrogenic milieu, the risk of response to the hyponatremia or the cerebral adaptive mechanisms are different, but that is just conjecture.
Yeah.
But one thing is certain, that risk factors which predispose them to osmotic demyelination lie more in other comorbidities, especially alcoholism, chronic liver disease, and the sodium level at which you start. Somebody who has a very low sodium level to start with, whether it is acute or chronic hyponatremia, you have to be very careful in correcting them. The lower the sodium, the higher the risk of having osmotic demyelination.
Right. So maybe quickly now back to Professor Sahai. There's a question from Dr. B.S. Gupta, who wants to know how to manage hypokalemia in COVID-19, which is fairly commonly observed issue in COVID-19.
Hypokalemia. I mean, you're. I mean, I suppose you're suggesting
in acute COVID-19.
In the acute setting where the use of steroids, there could be various factors contributing to that in terms of steroid use, and in this setting, I think we need to initially assess what is the cause for that, what is contributing to the cause, whether to the problem, whether it's because of the sodium, renal losses, which is probably the major cause, and then we need to accordingly see that we are replacing adequate amount of potassium, and because in this setting we need to replace potassium and see that we are adequately covering the hypokalemia.
Right. And the question from Dr. Abhik Das, how magnesium is corrected in hypokalemia? You did mention that unless you correct hypomagnesemia, hypokalemia may be difficult to treat.
Yeah, in the acute setting, mostly we need to use intravenous magnesium correction, and that would obviate the need for potassium replacement, and it would correct the potassium levels. And but in the outpatient setting, we can even use some of the preparations of magnesium, oral preparations of magnesium that are available. But I think the major issue is in terms of the inpatient situations where we would use the magnesium, intravenous magnesium.
And there's a question, I think, on a very basic level, which maybe both Dr. Muralidharan and yourself could try and take it. You did mention about, we all know that insulin causes cellular shift, intracellular shift of potassium. So is insulin one of the physiological regulators of plasma or serum potassium level, of which then will require that the beta cells have potassium sensors, which will be different possibly from the potassium ATP channels that the beta cells do have. Any idea, Rakesh?
Insulin is not regulating the. In the sense, it is responsible for the intracellular shift of potassium, and that is not the major regulator of potassium, because the major regulation is through the renal and the GI losses which are happening. So it's only in an acute setting where there is hyperglycemia, and when correcting the hyperglycemia with insulin, we could face a scenario where there is hypokalemia developing, and that has to be kept in mind. Professor Muralidharan probably would add more to this.
Would you like to add anything?
Yeah, the most important applied aspect of this will be when you are managing a patient of diabetic ketoacidosis. If the patient has already low serum potassium, and normally in an acidotic patient, we expect that the potassium should be high. But in such a patient, if the potassium is already normal or low normal, then we should be very careful in starting insulin infusion first, try to correct the potassium. This is one setting where you first correct the potassium along with insulin infusion. Otherwise, you can precipitate a life-threatening arrhythmia because of rapidly oncoming hypokalemia. So that is the applied aspect.
Yes. We stay with Dr. Muralidharan. There's a question from Dr. Biswas, who wants to know whether hyponatremia causes TIA.
Because TIA by definition is any transient neurologic abnormality, which is a non-convulsive neurologic abnormality. What TIA you're mentioning, whether it is anterior circulation or posterior circulation, that is the question. Because anterior circulation TIA usually manifest in the form of a mono or hemiparesis or a transient monocular blindness, which is not a manifest. These are usually manifestations of hypoglycemia. But if you're looking at a posterior circulation TIA, like giddiness, vertigo, these can be manifestations of chronic hyponatremia. So many times patients who come to us with vertigo, slurring of speech, and frequent falls, if it is an acute onset, then rather than suspecting a neurological insult of a structural etiology, we should always get electrolytes in them, because many a time we pick up hyponatremia as a cause in elderly subjects who present as posterior circulation TIA, and once you correct the sodium there, many of the neurological abnormalities, they improve.
True. So essentially,
so we may say posterior circulation TIA, like manifestation as vertigo or falls, can be attributed to hyponatremia, but no, it doesn't manifest as a focal neurologic deficit, unlike hypoglycemia. In hypoglycemia, it is definite that it can present as hemiplegia, it can present as monoplegia, and that's why it's said that there is a famous aphorism when we used to do MBBS, we used to be told that no stroke is a stroke until it has had 50 ml or 50% dextrose in water. But that is not true for hyponatremia.
Yeah. So essentially, though it's not ischemic in origin, but it could be hyponatremia.
It can masquerade a posterior circulation TIA.
Posterior circulation TIA may co-masquerade.
Like,
right.
Because the patient may have vertigo, and you may be thinking that you may get an MRI, because in elderly subjects, MRI will show some abnormalities. In all the subjects, you will find some white matter changes, microvascular ischemia in the posterior circulation. So we cannot attribute everything to ischemia. It can be due to a reversible factor like hyponatremia.
Right. And there's an important question by Dr. T. Dave, which is partly answered, is which is better, bolus or continuous infusion for management of hyponatremia?
Now the recent consensus, both American and Europeans say that multiple boluses are better than continuous, because there is a fear of overcorrection in a continuous infusion. And as I told you earlier, do not aim for normonatremia. Try to correct in the first 2-3 hours in acute hyponatremia to just raise it by 4, because just raising the sodium from 118 to 122 will be enough to prevent the life-threatening complication of cerebral edema and tentorial herniation. After that, we can go slow. The first few hours, you try to be aggressive in acute hyponatremia. For instance, a patient is throwing a fit, and you would like to correct maybe by 2 millicoulomb per liter in the first 1 hour itself. And in the next 2-3 hours, if you raise it by 6, then after that, you can make it 0.5 millicoulomb per hour. So that is why I said this formula will be easier. The body weight into the millimole per liter per hour correction required. So we can easily multiply by 1 or 2 or 0.5 and arrive at the infusion rate.
Absolutely. That's very practical. And then there's a question from Dr. Amit Singh. Hyponatremia in patients with acute inflammatory condition, how do you manage? I suppose you have to treat the basic condition and also maybe hyponatremia.
No, it depends on what acute inflammatory condition. 2 major organ acute inflammatory conditions are associated with hyponatremia. One is CNS and the other is lung, because in both of them, the etiology is same, SADH. So if it is really acute onset, so it will be like any other mechanism of acute hyponatremia management. But if it is subacute or chronic, then it will be like management of SADH. Like many a time we see in patients of chronic lung disease, they have persistent
tuberculosis
because of SADH. So in them, we may use tolvaptan or any of these agents, Vaptans, in a judicious manner, at the same time doing water restriction as well as oral sodium. So it depends on which etiology we are talking about.
And that brings us to a question on Vaptans by Dr. Atul Garg. So by the European guidelines, so what is the indication of use of Vaptan? Is it only for heart failure?
No, they have ruled out Vaptans for everything. Because heart failure, whatever studies were shown earlier, Everest study is one of them. They said that even though it improves hyponatremia, it doesn't really improve the final outcome of the patient. Earlier, they said if somebody is waiting for a cardiac transplant, in addition to the other supportive management, if you use Vaptans, it can act as an aquaretic agent, because in contrast to diuretics, Vaptans will cause selective water loss, so the patient can have relief from congestive cardiac failure without the complication of hypokalemia. So that was the hypothesis. But now what they have shown is that most of the trials have shown that the final outcome of congestive cardiac failure is not improved by Vaptans. And that's why the European guideline says do not use Vaptans in both hypervolemic as well as SADH. They are batting more for urea,
which is, of course, not available to us. You did mention a product that may be ordered over the Amazon.
Yeah, some neurologists, one of my friends who is a neurologist, he is more confident in using urea because in neurology literature, somehow urea has been advocated more than Vaptans, even before Vaptans were invented. Because urea, I didn't show that slide, it has been shown in experimental animals to be neuroprotective. It has a good effect on glial cells. It actually has a trophic effect on astrocytes. And that is why urea prevents osmotic demyelination syndrome. And one interesting thing was when patients of chronic kidney disease develop hyponatremia, and if you even inadvertently overcorrect them, they somehow don't go into osmotic demyelination syndrome, thereby implying that high urea protects the CNS against osmotic demyelination. That's why urea is preferred. But the only problem is its palatability, and it has to be always combined with soda bicarb, some lime, and there is a sweetening agent. So now a ready-made agent is available, which will, if we can tell the sponsors of this program to explore the option of getting urea into our country and make it available for our patients, we can try.
Right. So we shouldn't use the term uremic encephalopathy, because urea should be protective actually for the brain.
Urea is protective for osmotic demyelination.
Yeah. Okay. Yeah. And then a question about hyponatremia with flozins, gliflozins. Is that a problem?
No, it's not a major issue, because here you get loss of all the electrolytes. It is not just, if you have only excessive loss of, definitely, yes, it can be one of the causes of depletional hyponatremia in elderly subjects. If somebody is already on diuretics and somebody is taking a poor intake or hospitalized, I would always try to avoid use of this agent. And if already somebody is taking it, then I would stop it, because this can aggravate the problem of the excessive free water as well as electrolyte losses. Just like diuretics, this can be another cause for depletional hyponatremia.
Yeah. So that was a question from Dr. Rajesh Agarwal. So finally, we can go on for the entire rest of the night, but we have to bring it to an end at one point. But we have a very interesting question for Professor Sahai. This question from Dr. Zaid. It's a 30-year-old lady diagnosed with primary hyperaldosteronism, classical features, severe hypertension, hypokalemia, started on spironolactone. On next visit, she was found to be pregnant. Or what to do now? Dr. Rakesh Sahai.
Yeah. So this is a scenario where we are seeing a lady who's diagnosed with classical primary aldosteronism becoming pregnant, and I think this will require that she would have to be medically managed only, and this is a particularly challenging situation, I think, where we need.
Yeah, we need to, of course, discuss with the patient the pros and cons, and would Dr. Muralidharan, with his wisdom, add something?
No, spironolactone is definitely being an anti-androgenic agent. It blocks the effect of androgen biosynthesis as well as action at the receptor level. So we would first get a gender. This is one indication where we will do the gender of the fetus. If it is a female gender, then we can stop the spironolactone and allow the pregnancy to continue. If it is a male gender, because she has been exposed to spironolactone during the period of organogenesis, we would like to advise MTP. That is why we have to be very cautious in these patients before starting this agent, whether they are going to be pregnant or whether they're going to plan pregnancy in the near future, and advise appropriate contraception.
Right. So I would like to thank once again both of you for the excellent deliberation and the way you dealt with all the questions. And of course, the 1,000+ attendees, I mean, even so long down into this program, still we are touching more than 1,000. And the interest that is kindled in them, I do hope it also helps them in their practical day-to-day practice. And of course, this is possible, I'm sure, because we have got excellent faculty like Dr. Muralidharan and Professor Rakesh Sahai. So my sincere thanks to both of you for sparing your Saturday evening. And I had to leave the match, the T20 match, where India was in a strong position, and I have to go back to that and over now to Intus, who also I'm thankful to for providing this platform over the last so many months. Over to you.
Thank you.
Thank you, Professor Chaudhary, sir. I think it's your wisdom that has made this program what it is today, and the kind of topics, the clinical topics that you give, that generates immense amount of interest among physicians of this country. And we are very happy to have such eminent speakers which you guide us to bring on this platform. And we are very fortunate to have Dr. Muralidharan and Professor Rakesh Sahai on this platform today. And I must say thank you to both of them for their excellent deliberations today. And there were a lot of interest which was generated. As Professor Chaudhary has already mentioned, we had more than 1,000 delegates on the platform. And I must say thank you to all of them for sparing their valuable time and coming on to this platform. I know my team is constantly in touch with them, following with them, because there is a lot of webinars happening these days. But I feel these are topics which are very relevant in today's scenario and very clinical topics. So I'm sure these topics are helping them to manage their patients in a better way. So on behalf of INTAS, Zenith Division, makers of Dapawell and T-Glip, I thank you all for sparing your night and missing the T20 match. It's going on, it's very interesting. And I'm sure we have got some take-home messages from today's sessions. So once again, thank you, Dr. Muralidharan, Professor Rakesh Sahai, and of course, Professor Shubhankar Chaudhary for being here and guiding us for these programs. So we will have next program on third Saturday of next month on PCOD, as Professor Shubhankar Chaudhary has already given the topic. So we will have the best of the faculty for the program. So thank you very much once again, and good night to all of you. Thank you.
Thank you. Very good night.